In the current climate of uncertainty, there is a real risk that medical practitioners will adopt defensive medicine. There is evidence that this is already happening, fearing that they might be caught out should a complication occurs. Doctors are likely to overwhelm patients with voluminous information on multiple unlikely risks, protecting themselves legally but confusing the patients. This will be highly detrimental to Singapore's healthcare system and will damage the trust between doctors and their patients. We should guard against turning into the kind of society where doctors care more about not being sued or disciplined by the professional body than about the patient's well-being. This is a well-traveled road elsewhere with very predictable consequences. The United States is a prime example of a healthcare system where large sums are awarded for medical negligence. A significant fraction of healthcare costs goes towards medical indemnity insurance, and the patient and society as a whole end up bearing these costs. We will address this and provide clarity and guidance in two ways. First, the work group that is reviewing the SMC disciplinary processes will also review and study the legal and practical applications of taking informed consent. They will evaluate the local practice in different settings, as well as study the practices in other jurisdictions. The work group will also consult widely on this and seek views from the medical community as well as the public. It will make recommendations to the government on every aspect of informed consent and give guidance to the medical profession on what, where, and how in taking informed consent. The intent is to address the needs of the patients whilst providing the medical community with clear practical guidelines so that doctors do not have to second-guess what is needed in each case. It will also consider whether legislation will be necessary in order to achieve these objectives and to set out the tests to be applied. We should, however, remember that the relationship between the doctor and the patient is not only unique in each case, but also dynamic. It will evolve over time and change with each diagnosis and advice given. It is therefore not possible nor desirable to be overly prescriptive in such guidance. There must always be sufficient flexibility in any test or guidance which we formulate, so that ultimately patient interests are best served. Doctors know that patient welfare must be paramount. Second, to provide additional practice guidance to the community, Ministry of Health intends to issue legally binding clinical practice guidance in specific areas. We aim to give healthcare professionals more certainty on aligning their practices with the rest of the healthcare community and on discharging their ethical and legal obligations to their patients. For example, on the issue of informed consent, the guidance would explain what nature of information would be considered to be relevant and material to the patient. Such guidance will not be confined to the issue of informed consent. For example, guidance can also be issued on how healthcare institutions and professionals should handle requests for assistance from patients' next of kin, and in particular, verify the identities of the next of kin, question raised by Dr. Chia and Dr. Lim. The approach will be balanced, protecting patients' interest and welfare, yet being fair to doctors. There should also be consideration for practical issues, such as what to do in an emergency situation. MOH will engage the medical community and the public before issuing the guidance. Sir, as I said earlier, the Court of Appeal has also made some suggestions in the civil suit against CGH on the responsibilities of radiologists and institutions. The Court of Appeal's central concern in that case was to ensure that radiological reports with adverse findings are followed up with appropriate speed and care. This ensures patient safety, and we agree entirely with that. The question, however, is how best to achieve this. Arising from that decision, healthcare professionals and institutions have told us that they need clarity on the level of responsibility that radiologists bear. They also need clarity as to whether radiological reports with adverse findings should be returned to the doctors or teams who had ordered them, or should they be routed to another specialist department for follow-up. The position hitherto has been that radiologists are not expected to bear any primary care responsibility when there are adverse reports, and that such reports should be routed back to the doctor who ordered the tests. That has worked well for us, and my ministry believes that this is probably the best approach. We will consider the position carefully. My ministry will also study the existing legislation with a view to setting out in legislation what should be the legal and ethical responsibilities of the doctor involved and the institutions, and how reports with adverse findings should be routed. This should give greater clarity to the community. So, to conclude, the medical community that we wish to have is built on the mutual trust and respect of the patients and the public. Doctors are expected to uphold the highest possible standards of professional and safe medical practice, where patients' interest is always at the core. Patients must trust their doctors and be able to rely on them to look after their interests and well-being. Our doctors, in turn, need to be able to practice in an environment where they have clear guidance and not be burdened with the uncertainties and vagaries of unwarranted sanctions or litigation. We have quite a lot of work to do to achieve this, but we are confident that we can do so. We will work through the initiatives described earlier to build a better healthcare system for all. Thank you.